Também não vai amanhã, não sei se vai vir pela batata, então.
Até já.
So it's 3:01, at least at my watch here. So I think we could start with our little webinar. I welcome all of you to this RumaPreg Highlights webinar that we like quite fast designed for you all. With the rapporteurs, which I will introduce to you in just a minute. And I'm really, really excited and happy that I see already like almost 80 people in here. So I really do think there is an interest in this and why we put this up and what we want to do today. To tell you this, I would first of all like to invite Clara and Antonia, our two lovely hosts from the RumaPreg 2025 on stage to give a short welcome and introduction.
Welcome, everybody. We are Antonia Mazzucato and Clara Rosta. We are rheumatologist and gynecologist. And we had the honor to host this year's RumaPreg Congress in Vienna.
And I don't know, Isabella, if you would like to show the slides already. So this meeting was a great success with participants from all over the world. We had more than 430 participants from more than 45 countries. And of course, we would like to share the information which was discussed there with all the audience who couldn't attend in Vienna, but has interest. And this was made possible by the Euler Study Group for Reproductive Healthcare. Thank you for Laura and Karen for giving this seminar webinar platform. I would also, we also had a very interdisciplinary audience and an interdisciplinary lecture team. We had 1/4 obstetric, 2/4 rheumatology, and 1/4 from other specialties.
And then we give the word back to you, Isabel, and want to thank you. Thank you very much for all your work for organizing this webinar.
Yeah, thank you so much for this kind introduction. As you already said, RumaPreg 2025 was really a great, successful event. I think we really can say it united attendees from all over the world and from different specialties. And since not everybody could have been there live in Vienna, beautiful Vienna, we took together a group of so-called rapporteurs to present the highlights from this meeting to you today. And first of all, I would like to give you a short overview of who we are. So these nice 8 people that you can see here prepared the highlights, the presentations that you will see in a few moments. And sadly, 2 of them can't be with us today. So Valerie, who you see from Vienna, and also Louis are busy in clinic and on other conferences. So it's up to us 6 who are here today to bring all the highlights to your homes. And yeah, without further ado, I think we will start with our agenda. And we have splitted the highlights into 3 parts, into 3 little sessions, let's say. The first one will deal with fertility, with the hormonal factor in rheumatic diseases. We will have a little spotlight on the placenta and what it might cause during pregnancies, and also, which was a very interesting debating session on recurrent implantation failure and miscarriage. The second part will deal with the more like rheumatological focus. Always a highlight is what we know new about pregnancy in SLE. Of course, obstetric APS is also always causing us some headaches. Then we will have a overview what's new on reproduction with RA, connective tissue diseases and vasculitis. Always important, update on immunosuppression and some long-term postpartum challenges. And last but not least, we have a short third part where we choose some out-of-the-box presentations which dealt with ethical issues and the inclusion of pregnant people in clinical trials. So we hope that this is also of interest for you. After each block, and that's the maybe only thing I have to tell you for the housekeeping, we will have a short Q&A session. So we would like to ask you to put your questions into the chat. We will go through them. We might not be able to answer all of them since we have a quite tight schedule, but we will pick out questions and answer them in between. So with that, I would like to introduce Christina Hörhager to you. She is one of the locals from Vienna. She is a PhD student in reproductive medicine, and she will start to tell us something about fertility and the hormonal factor.
Good afternoon, everyone. I'm Christina Hörhager, and I am actually a diploma student of Dr. Roster at the Medical University of Vienna. And I'm going to start with the first session that was presented at the RheumaPrag this year, which was on the challenges of fertility in the context of rheumatic disease and social changes. Now you can change to the next slide, thank you. Family planning keeps getting postponed nowadays, even though the biological reproductive lifespan did not change, with a peak in fertility between the ages of 20 and 35 in women, with an increase in abortion rate and a decrease in live birth rates after the age of 35. However, societal temporality about family planning differs severely from that. That might be due to societal expectations or also career choices of the women, for example. And due to optimized medically assisted reproductive techniques, reproductive lifespan seems to be prolonged. The biological reproductive lifespan, however, varies interindividually. And therefore, in some cases, it might be interesting to measure the ovarian reserve in a woman to know at what point of the reproductive lifespan the woman is at. Can you change to the next slide, please? The ovarian reserve is an estimation of future fertility. But it's really important to note that this is not a perfect marker for fertility. And it should not always generally be used, and it should be interpreted really carefully as a marker for future fertility. So what measurements do we have? On the one hand, we have the biochemical tests, which include the AMH, the FSH, and inhibins. And on the other hand, we have the ultrasound measurements of the ovary. That's the antral follicular count. Next slide, please. The two most important ones are the AMH and the antral follicular count. Yeah, now you can change, thank you. What about the ovarian reserve in rheumatic diseases? Current studies show contradictory results on the AMH levels in rheumatic diseases. Next slide. And if we look at this big meta-analysis on AMH levels in SLA patients, we see decreased AMH levels in SLA patients, which was mainly associated to cyclophosphamide intake. Next slide. So how can we approach infertility in rheumatic diseases? We need to keep in mind that chronic inflammation medications impact fertility, like cyclophosphamide, corticosteroids, or NSAIDs. Increased prolactin in lupus flare and also autoantibodies might impact the ovarian function in rheumatic diseases. However, a well-controlled disease activity is quintessential for optimizing changes of conception. So if a woman fails to conceive after 12 months of unprotected intercourse, the best scenario is an interdisciplinary infertility workup. Next slide, please. In which a rheumatologist optimizes the disease-specific factors, like disease activity or medication intake. And on the other hand, a gynecologist optimizes gynecological factors, but also never forget the male factor and general lifestyle factors. And if a woman needs more time for optimizing underlying disease, fertility preservation options might be needed. Next slide, please. So it's really important to be aware on what options we have here. We might do an oocyte or embryo cryopreservation. That can be done in post-pubertal women if 2 to 3 weeks are available, because an ovarian stimulation with a followed egg retrieval has to be done. And this is not just going to happen from one day to another. Another option would be the administration of GnRH agonists additionally to cyclophosphamide medication. This downregulates the pituitary with a reduction in ovarian activity, which can lead to a reduction in cytotoxic effect of the cyclophosphamide. Another option can be the ovarian tissue cryopreservation that might be performed in some special scenarios, for example, like prepubertal girls. But this is not a first-line choice in rheumatic diseases. Next slide, please. The ACR guideline published in 2020 addresses fertility preservation in rheumatic diseases, and it highlights the possibility of a controlled ovarian hyperstimulation if a woman is in remission or at a stable low disease activity. Another thing that's really important is the assessment of the APL status, as this determines the need for low molecular weight heparin therapy during and after the procedures. Next slide, please. I will now continue with the hormonal factor in rheumatic diseases, next slide, in which we learn about the complex and sometimes dose-dependent impacts sex hormones like estrogens, androgens, and progesterone have on the immune system. Due to those complex interactions, patients and also doctors often avoid contraceptives who contain hormones in patients who suffer from rheumatic diseases. Sorry. Which leads to an underusage of contraceptives in those patients, which might also increase the rate of unplanned pregnancy with a higher rate of adverse pregnancy outcomes in those patients. So it's really important to know when and how to use contraceptives right. Next slide. In general, any contraceptive can be freely used in any rheumatic disease, except from an active SLA and also in women with a positive APL status, because in those patients, estrogens should be avoided. On detailed guideline on contraceptive use, refer to the ACR guideline published in 2020. Next slide. And before avoiding contraceptives out of fear, please refer the patient to an interdisciplinary counseling center. Next slide. The next presenter addressed the issue on hormonal replacement therapy in rheumatic diseases. Menopause might mimic typical symptoms of rheumatic diseases, and this fact should be addressed in women. The prescribing pattern, next slide, please. The prescribing pattern of HRT is similar to the one of contraceptives, meaning women with rheumatic disease without an SLA and with a negative APL status should be treated according to the general population. Of course, after considering the general risk factors of HRT therapy. So if a woman is diagnosed with APS, HRT should be avoided. And if a woman has an inactive SLA and a negative APL status, HRT can be used if it's needed. In women with a positive APL status and no diagnosis of APS, the decision on HRT depends on the current APL titers. So if the current titer is positive, HRT should be avoided. And if the current titer is negative, HRT can be used if it is needed. Thank you for your attention.
Thank you so much, Christina, for which was really a perfectly on-time overview of these two important topics. And I would like now to call to, on stage, let's say, Luisa and Susanna. Luisa Pinto is an obstetrician from Lisbon in Portugal, and she has brought her rheumatologist, BFF, let's say, Susana Capella, who also works in Lisbon, Portugal. And they now will present the second part in this block 1 to us, which, first of all, will deal with placental pathology. Luisa, Susanna, are you there?
We are there. You may move to the next slide, please.
Perfect. Thank you.
Thank you so much. My name is Luisa Pinto, and I'm an obstetrician from Lisbon, Portugal. And I'm going to talk a little bit about the mechanisms for the pathogenesis of pregnancy complications in SLE, specifically trying to address the importance of placental alterations. So we all know that there are several mechanisms involved in the pathogenesis of lupus, like hormonal mechanisms, inflammatory and immunological mechanisms. But we also know that placental alterations have a huge importance in lupus. But these alterations are several. They can be immunological, vascular, inflammatory. Just as a curiosity, the weight of the placentas of women with lupus are decreased in more than 50% of these placentas. And also, placentas with low weight are associated with stillbirth. But let's see a little bit more about this issue. Next slide, please. So we all know that placenta has a determinant role in obstetric outcomes. Probably the most known one is its implication in preeclampsia and intrauterine growth restriction. And we know that this is caused by a deficient spiral artery remodeling that leads to placental hypoxia, then to an imbalance in relation between S-FLEET and PLGF, which leads to endothelial damage and then ultimately to multi-organ damage. But what else do we know about placenta in the obstetric outcomes? Next slide, please. The classical model was the two-stage model that defended that early onset preeclampsia was associated with poor placentation, but late onset preeclampsia was associated with maternal factors. This model has been questioned in recent years. And it seems, next slide, please, that it's more correct to think that early and late onset preeclampsia results from placental stress. In a first stage, there is placental dysfunction, and in the second stage, there come the signs of an organ dysfunction. What differs are the causes and the timing of this placental malperfusion. In early onset preeclampsia, yes, there is a deficient spiral artery remodeling, and in late onset preeclampsia, there is an intervillous malperfusion from mechanical restrictions, and when the placenta reaches a determined size, malperfusion and hypoxia occurs. So this is one of the models that nowadays stands for the basis of preeclampsia. But another model has also been described. We know that women with preeclampsia are at higher risk of cardiovascular disease later in life. This effect is dose-related, which means that the more the number of pregnancies complicated with preeclampsia, the more the risk in a subsequently in life of developing cardiovascular disease. And we also know that the earlier the delivery, the greater the risk. This information is not only crucial for the follow-up and prevention of cardiovascular diseases in these women, but also leads to another hypothesis. Next slide, please. Which is the cardiovascular maternal model. Which comes first? Placental dysfunction or cardiovascular dysfunction? So does everything begin in the placenta and then there's a generalized affection of all the organs, or the dysfunction is already there? There is a mother with some cardiovascular defect that during pregnancy does not really keep up with the requirements of pregnancy. And then there's an hypoperfusion and everything develops from there. So in fact, I think actually we don't know what comes first. So now regarding the role of placenta in obstetric outcomes in women, specifically with lupus, the fact is that we don't know much about this. We know that there's complement deposition, immunoglobulin deposition, but the studies are very scarce, including low number of patients, and moreover, disease activity and the therapy the patient is taking were not considered in these studies. Maybe the better knowledge of placental mechanisms could improve and help in prediction, prevention, and treatment of these women. What about placental pathology and fetal loss? We also don't know much. We know that placental dysfunction occurs in 30 to 60% of stillbirth, but we have a main problem, a basic problem, the lack of standardized nomenclature. And in this RomaPreg, it was highlighted that, next slide, please, the first that we should do is to have the same classification. And this was the classification proposed by Raymond and that we all should use in order to have an homogeneous approach of these situations. Thank you. Sorry. Okay. Now, regarding fetal loss and deficient implantation, we know that there are lots of histologic patterns that are more common in women with APS, from fibrin deposition to maternal malperfusion. And so placental evaluation in fetal loss may also improve risk assessments and eventually allow targeted therapy in a future pregnancy. Next, please. And now also on me, I'm going to talk a little bit about immunomodulation for recurrent implantation failure and miscarriages. So we know that maternal fetal immune tolerance is absolutely necessary for a successful implantation. And we also know that several therapies have been explored in order to increase the success of pregnancies. However, next slide, please. However, we need to understand the basis of recurrent pregnancy loss and of recurrent implantation failure in order to avoid these situations. And we know that these situations both share a common basis in maternal fetal intolerance. However, they both also present heterogeneous etiologies, mainly heterogeneous immunological alterations. So it's impossible to have only a single immunological approach to these situations, and that's suitable for all patients. The first checkpoint is blastocyst implantation. And in this blastocyst implantation, we have two intervenients, the trophoblast, the decidua and the trophoblast, and the blastocyst. Next slide, please. And we know that most of the immune alterations that occur in recurrent pregnancy loss are endometrium-based. In fact, the decidua has an important role in controlling embryonic quality. And if the embryo is not completely perfect, organogenesis will not be successfully completed because the hypoxic environment and the oxidative stress will lead to an incomplete embryo development. However, the most important factor for pregnancy loss is the embryo, and we know that many embryos do not progress in its development because of genetic or chromosomal defects. That's why immunomodulation is not recommended, except in women who have autoimmune conditions such as lupus, autoimmune thyroiditis, celiac disease, and inflammatory bowel diseases. Next, please. So, and as a take-home message, recurrent fetal loss and recurrent implantation failure remain a complex growing problem, but they have several etiologies, mechanisms, and treatment options, and identifying the causes and providing individualized treatment could improve implantation rates. Today, treatment remains a challenge, and further research on these treatment options is needed so that we can have standard protocol for these patients. Thank you very much.
Thank you so much, Luisa, for this run through placental pathologies and an ongoing debate, I think, with the recurrent miscarriages and implantation failure. So now would be time for our audience to have a first quick Q&A session on these first presentations. I haven't received anything from Laura, who is luckily watching the chat for us. So I will maybe just wait a few seconds if anybody comes up. Otherwise, we can move on. And if some questions arise for this first part of our webinar, then we can also try to get back to them later on. So, as I don't see any questions so far, of course, I could ask a lot. Your presentations were gave so nice impulses, but I think I will spare that for the end if we have some time. And so I would suggest we move on, and we now move from Austria and Portugal to Italy. And I would like to welcome Francesca Crisafulli from Brescia. And she will move over to a classic topic, pregnancy in SLE. So I have to take a look here. Yeah, I see Francesca and I see her unmuted. So I will give the word to you, Francesca.
Hello, good afternoon, everybody. Thank you, Isabel, for the introduction. So let's start with walking through lupus session. Please, next. And in the first session by Ian Giles was about how to manage advanced new therapies during pregnancy in lupus. And we know that the landscape of treatment for lupus is growing, and there are a lot of treatments on ongoing trials. Next, please. And another time next. So that it's okay. But actually, we have low pregnancy evidence, even for treatment already approved for the treatment of SLE, such as belimumab, anifrolumab, and voclosporin. And of course, these data are even less in treatment that are ongoing trial. Next, please. And so Professor Giles show us what is the UK Teratology Information Service approach when data are absent or low for drugs. This approach evaluates some key questions, such as, does the drug cross the placenta? What is the target molecule, and if is it involved with fetal development? Are there any human or animal data? And again, are there any neonatal immunologic implication? And finally, crucially, I will say, what is the impact of an uncontrolled disease, and what is the risk versus benefit balance? So he also discussed how and when consider the novel therapies and during pregnancy. And the answer is maybe in extremis. So in extreme situations such as severe maternal disease, when no other pregnancy compatible drugs are available or suitable for the mother, and maybe during the second, third trimester, always considering the structure and the class of the drug that we are considering. Next, please. And also in situations such as accidental exposure, he suggested to have a thoughtful and reassuring approach with the patient, so don't panic. And finally, another key point of his presentation was about the need to include pregnancy in clinical trials, but we will see this topic later in the last session of this webinar. Please, okay. So the second presentation was by Professor Frisch Stork from Vienna, and it was on the importance of a complement in SLE. Due to time constraints, I will focus only on pregnancy data. So, thank you. The classical pathway is the pathway better explored in this field. Mainly C3 and C4 had different studies, and few studies show an association of low C3 and C4 at preconception with preterm births, and other studies show an association of low C4 at preconception with the flare during pregnancy. However, these results were not confirmed by a recent meta-analysis. By the way, here the key point is that it's not just a matter of C3 and C4 level, but what is important is the variation of C3 and C4 throughout pregnancy. And indeed, the lack of physiological increase in C3 and in C4 in the first part of pregnancy can be associated with the flare or adverse pregnancy outcome, as shown in a recent network meta-analysis. Next, please. And also the alternative pathway and the regulatory complement factors H and I were addressed, but data here are limited. Please, next. And finally, Professor Sciascia talked about lupus nephritis and preeclampsia, focusing on how to differentiate between these two conditions. We know that both lupus nephritis flare and preeclampsia can occur during pregnancy, and the differential diagnosis is crucial because the treatments, of course, are very different. Next, please. And indeed, sometimes the diagnosis could be challenging because we have overlapping features that you can see here. But next, please. There are also some features that are more typical for lupus nephritis or for preeclampsia that can help us in the diagnosis. And Professor Sciascia, in his presentation, highlights another time the role of complement. Next, please. And also, next. Okay, and also the SFLT1 PLGF ratio, already cited in the previous presentation, that is elevated in patient with preeclampsia. Next, please. And then beyond the conventional biomarker, he explored the upcoming biomarkers. Here you can see some biomarker study in the field of lupus nephritis, regardless pregnancy. And there are also, next please, preeclampsia biomarker. There are a lot with different sensitivity and specificity. And finally, next, there are also other tests that need to be validated in the field of rheumatic and lupus pregnancy. Next. So due to time constraints, I cannot go deep dive into the 2 oral presentation and into the poster, but I really suggest you to read the abstract when they will be available on the abstract book. So thank you very much for the attention.
Thank you, Francesca. It was a great overview, and I think really also some new biomarkers, etc., on the horizon coming up to help us maybe next year or some years after. But now we will quickly hand over back to Portugal, to Luisa and Susanna, who will try to give us some ideas how to manage another often problematic feature in our patients, namely obstetric APS. Susanna and Luisa, I'm handing over back to you.
Hello, good afternoon, everybody. It's great to see so many of you here during lunch break. So me and Luisa, we have prepared our highlights together so that it could be clear either for the rheumatologists audience and as well for the obstetrician audience. And so now we are going to bring you the RheumaPreg highlights on obstetrics antiphospholipid syndrome. So as you all know, in this syndrome, we have vascular thrombosis and or pregnancy morbidity. And we are always talking in the presence of antiphospholipid antibodies. It is very clear for rheumatologists, but sometimes obstetricians are not so aware of the non-criteria clinics of this disease. So there are non-criteria, non-thrombotic manifestations like livedo, cardiac valve thickening, cognitive impairment, and thrombocytopenia. And we can talk about obstetric APS, so obstetric antiphospholipid syndrome, in patients that have persistently antiphospholipid antibodies and obstetrical complications. So these complications can vary from patient to patient. They can include early or late pregnancy losses, preterm delivery before 34 weeks of the gestation, and that are due to either severe preeclampsia or eclampsia or due to placental insufficiency. Next slide. So we have different classification criteria, and these criteria have been created and designed as most of the classification criteria to define homogeneous and well-selected cohorts. And these are the cohorts that are most appropriate for use in clinical research. And so the new criteria from 2023 from the American College of Rheumatology and the European Alliance of Associations for Rheumatology, so ACR and DOLR, have been presented. And so just to remind, it's a new score, it's a new classification with a scoring system. So the different criteria have different weights and are organized in either clinical or laboratory domains. So we have 6 clinical and 2 laboratory domains. And to be classified as APS, the patient must have at least 3 points, each from the clinical and laboratory domains. So there's this weight, this weight and organization is different from last classification criteria like the Sapporo, and the presence of only anti-cardiolipine or anti-beta-2 glycoprotein 1, the IgM isotopes without the positivity for IgG has a lower weight of only 1 point. And this is important in clinical aspects because we don't have the two necessary to classify. So as I've mentioned before, the complications may vary and include in general the same type of manifestations. More than 3 early pregnancy losses, at least 1 fetal loss after the 10th week of gestation, morphologically normal fetus, and this preterm delivery caused by preeclampsia, eclampsia, or placental insufficiency. However, these criteria introduce they stringent the details for pregnancy morbidity, attributing a higher weight to the presence of severe preeclampsia, eclampsia, and to placental insufficiency. However, and this is very important clinically, if we do not have preeclampsia, eclampsia, or placental insufficiency, the other obstetric manifestations are only attributed 1 point, which is not enough to the diagnosis. Next slide, please. So, of course, for trialists, these ACR-LR criteria are great, are very exciting, and it's thrilling to have the homogeneous group of patients that we need to enroll in clinical trials, and we do need those trials. They allow better patient certification, and of course, they also allow an improved validity and consistency. So they are very good for us to use in clinical trials, and we have to do more trials because we need them actually. Next slide. But concerning our clinical activity, we have to see that in this new classification criteria, we have a decrease in sensitivity linked particularly to the obstetric domain. So early and late fetal losses, which are so important for us, but especially for the patients, which is what we are worried about, this early and late fetal loss. They are in fact underrepresented, and the same happens with the patients carrying only IgM for anti-cardiolipine or anti-beta-2 glycoprotein 1. So there are patients that have the disease that we need to treat with fetal losses that do not meet, they may not meet this criteria, and we recognize those patients in clinical practice. So there is an important message to take home, and this one is to decide treatment according to the manifestations of the patient, considering non-criteria manifestations as well, and according to obstetric history. So clinical decision still prevails in taking care and aborting the end with these patients. Next slide. So we all know the standard of treatment is low-dose aspirin and low molecular weight heparin, but the fact is that it fails in 20 to 30% of women. We do have a lot of alternative therapeutic options like prednisolone, immunoglobulin, hydroxychloroquine, but the fact is that only a few interventional trials and randomized controlled trials have been done, and not in the last decades. So mostly the data we have is from retrospective cohorts. Next slide. So there is a lot of research with highlights the research on clinical trials ongoing with hydroxychloroquine, either in refractory obstetric antiphospholipid syndrome cases, but also as a standard therapy. And we'd like to point out that Hypatia is still recruiting patients, and you are free to call them to see if it's possible still to enter in the study. Concerning other treatments, we have immunoglobulin, either as a single-arm treatment or in combination with other treatment. Mixed results. There are treatments with rituximab, statins, ongoing still. Concerning biologics, we'd like to point out the IMPACT trial that was presented in the Congress. So really great promising preliminary data with the use of certolizumab in refractory OAPS cases. So this is what we had about OAPS to show you. And now we continue with the news on reproduction, on other diseases. And we will start with inflammatory arthritis. And so we are bringing you what we have from the Congress about rheumatoid arthritis. A study was presented comparing the pre-CARA cohort and the CARA cohort. And remind you that the pre-CARA is the preconception counseling in active RA cohort. So this cohort includes RA patients with a wish to conceive or that are already pregnant and they are treated with a treat-to-target approach. This group was compared to another cohort of patients that some of you also know, the PARVA study. So the pregnancy-induced amelioration of rheumatoid arthritis. This is a historical reference cohort. So we have the new treat-to-target approach that we all use in rheumatology nowadays, and we are comparing it with the standards of time of treatment from 2002 to 2010. Next, and so a treat-to-target approach is adapted for pregnancy and aimed at remission of RA. And the study showed, in fact, that this treat-to-target approach is contributing to shorter the time to pregnancy and to lower the incidence of subfertility. But this is important. However, the use of TNF inhibitors was not directly associated with time to pregnancy. So time to pregnancy is reduced, but not directly related to TNF inhibitors. Next slide. So in fact, we can say that this modern approach, this approach that we use every day nowadays in our clinical practice, is also applicable to patients that are pregnant. So 90% of pregnant patients with RA manage to have low disease activity, LDA, or remission. So this low disease activity or remission should also be our aim in this group of patients. So of course we have restrictions on medications that we are going to use during pregnancy, but we should have the same goal that is to have the target in low disease activity or remission. Next slide, please. And other connective tissue diseases were presented. Professor Marta Mosca brought us an article from 2024 about pregnancy outcomes in an umbrella review. Next slide. So all autoimmune conditions really had a higher rate of cesarean section versus general population. And in fact, miscarriage was more frequent. There is a risk of miscarriage in patients with SLE, with Sjögren's syndrome, and with systemic sclerosis. And we can say about preeclampsia that SLE and systemic sclerosis patients have a higher risk of preeclampsia, but Sjögren's syndrome did not have a higher risk of preeclampsia, just of miscarriage, but this risk is important. Next slide. So now we are going to talk a little bit about Sjögren's syndrome, mixed connective tissue disease, idiopathic inflammatory myopathy, and systemic sclerosis. So the news is that most patients have at least one pregnancy. In fact, in the last years, patient outcomes have improved a lot, but we still have to work on adherence to therapy. It may be a problem, especially if different specialities give different advices. So it's important to have the same target from rheumatology, obstetricians, and other specialities. Next slide. So some of the flares that can happen in children for the obstetrician audience are like purpura, parotid swelling, thrombocytopenia, arthritis, neurologic involvement, but they are not very frequent. In fact, there is a low risk of obstetric complications, but we have to point out that the risk of miscarriages is higher than in the general population. So as I said, not the risk of preeclampsia, but we should consider, it's not a guideline, it's not a rule yet, but we should consider, start to think about low molecular weight heparin to reduce the risk of fetal loss in these patients. That was the opinion of Professor Marta Mosca. And we do have to monitor antiphospholipid and anti-RNP antibodies. Next slide. About mixed connective tissue disease, there is also an increased risk of maternal and obstetric conditions. And we have to say that the cases of maternal deaths, there were some cases of maternal deaths reported, but were mainly related to pulmonary hypertension. So there is an importance to screen these patients, either for pulmonary hypertension, as well as for interstitial lung disease. So before pregnancy, these patients must be screened preconceptionally. And of course, during pregnancy, we have to monitor blood pressure and to monitor renal parameters. There is also a potential role for aspirin. Preeclampsia risk was not significantly increased by disease activity in these patients, but disease activity seems to influence other risks, other adverse risks, like prematurity and fetal mortality. Next slide. So in myopathies, there is also a higher frequency of cesarean section, and patients that have the diagnosis of myopathies have worse adverse events after the diagnosis. Next slide, please. Concerning systemic sclerosis, in most patients, pregnancy is associated with a global stability, but some patients have a higher risk of worsening of the disease. So mainly vital organ involvement like lungs, heart, and kidney is the organ involvement that you should be careful and screen about. Next slide, please. So this is the vasculitis pregnancy registry. It was highlighted in the sessions because patients can self-enroll and report information on vasculitis. It's important for us to have data for preconceptional counseling, and you can show this to your patients and ask them because it's in different languages. Next slide. We have some data about vasculitis, so from this registry already, data from 16 countries and 147 women. And during pregnancy, most patients felt generally well. In fact, only 36% had active vasculitis, and from those, 5% had the need to be hospitalized. So these are the pregnancy outcomes that they have. Next slide, please. Also was pointed out the exploring reproductive experiences of these patients. So about this, we would only like to point out that patients do receive information from us, from our high-risk clinics and multidisciplinary teams. But many people still, half of the women said that they still need to coordinate communication among subspecialties. So this we have to work. Communication among our specialties. It's something that it was important for patients and still not done properly. Next slide, please. So this is all we have to tell you about. We have to maintain vasculitis like the other diseases, quiet, and we need to take care of about the prior and the current organ involvement, either preconceptionally or posteriorly during pregnancy. So this is all we had to bring you about.
Thank you so much. This was a really big overview over all our diseases, basically. And now that we know a little bit of details on each one of them, of course, we need to know how to treat them. And that's exactly where our Japanese repertoire comes in. I welcome Takehiro Nakai on the stage here. And he now has the important but also difficult task to teach us something new about immunosuppression during pregnancy in 2025.
Thank you very much. I will present immunosuppression during pregnancy and long-term outcome of the mothers and babies. Please go to the next slide. Start up from the 2024, you update the EULAR recommendation. EULAR recommendation covers three major topics: medication use during pregnancy and lactation, and paternal medication use, and live attenuated vaccination. So I will talk about the details. So please go to the next slide. And next slide, please. From 2016, EULAR, ABSL, and SCL presented the recommendations, and the EULAR updated the recommendation last year and published this year. And next slide, please. And here's a summary of the EULAR recommendations, and I will take a closer look at it. Please go to the next slide. And next slide, please. Start from the teratogenic medication. Methotrexate, MMF, and cyclophosphamide are contraindicated to use during pregnancy because of the teratogenicity. Please go to the next slide. In general population, 3% to 5% suffer from the congenital anomaly. However, please go to the next slide. However, if the patient is on the methotrexate, 10%, if the patient is on the MMF, 25%, if the patient is on the cyclophosphamide, more than 20% suffer from the congenital anomaly. So we should avoid their use during pregnancy. Please go to the next slide. And I will talk about the NSAIDs use. Please go to the next slide. NSAIDs use in the preconception period is linked to the increased risk of the luteinized and rupture follicle syndrome, which can eventually relate to the infertility. And please go to the next slide. And if we use the NSAIDs after 20 weeks of gestation, the risk for ductus arteriosus closure and kidney damage in the fetus will increase. So EULAR recommends to stop the NSAIDs at the later stage of the pregnancy, especially after 28 weeks of the gestation. Please go to the next slide. I will talk about the glucocorticoid use during pregnancy. Please go to the next slide. Glucocorticoid is sometimes used to control the rheumatic conditions. However, it has a risk too. When we use a glucocorticoid during pregnancy, it increases the risk of preterm birth. And please go to the next slide. If the dosage of the glucocorticoid increased, the risk for the preterm birth will also increase. So the EULAR recommends to reduce the glucocorticoid dosage to prednisone equivalent less than 5 if possible. Before pregnancy. Please go to the next slide. And next one is biological dimers. As for the TNF inhibitors, in line with the SCL and BSL, the EULAR also recommends the TNF inhibitor is safe to use during pregnancy. And go to the next slide. As for the non-TNF biological dimers, the SCL and BSL had a conservative stance to use the non-TNF biological dimers. However, this EULAR recommendation has more permissive use of the non-TNF biological dimers. They are allowed to use the belimumab, abatacept, and the IL-6 inhibitors and IL-17 inhibitors if their maternal disease is severe enough, and we need we need to control them. And please go to the next slide and go to the breastfeeding section. Breastfeeding is important for the mothers and baby to control, and it will decrease the possibility for mothers to develop the diabetes and the breast cancer, and it will protect babies from the infection. Please go to the next slide. And breastfeeding rate in the US is around 80%. Please go to the next slide. For the LMD patients, breastfeeding rate is about the same for the general population, around 70 to 80%. And please go to the next slide. The breastfeeding rate in the recent era is improving compared with pre-CAR cohort. It is a recent cohort, and para cohort it is a historical cohort. Breastfeeding rate is improving. This result may be result from the our better understanding of about the medication used during lactation. Please go to the next slide. And during breastfeeding, we need to be careful about the glucocorticoid use. Please go to the next slide. Prednisolone in concentration in breast milk peak approximately 2 hours after administration, and it drops rapidly. So EULAR recommends to stop breastfeeding for 2 to 4 hours if the mother was treated with methylprednisolone pulse therapy. So please go to the next slide. And I will move on to the paternal medication use. As for the paternal medication use, we should be aware of the cyclophosphamide use. Please go to the next slide. And if their father is using the cyclophosphamide, the sperm counts decrease, and the sperm motility also decrease, and abnormal sperm morphology will increase. And please go to the next slide. If the cyclophosphamide equivalent dose was more than 4,000, the risk for the impaired spermatogenesis will increase. So we need to be careful about this. Please go to the next slide, the vaccination slide, and please go to the next slide. As for the vaccination, we need to think about liver attenuated vaccines, and there's rotavirus and BCG. And as for the rotavirus, infant spontaneous inhibitor exposure can vaccinate the rotavirus. However, infants with the non-TNF biological dimers exposure during pregnancy should delay their use for 6 months. And as for the BCG vaccination, if their mother stopped the TNF inhibitors according to the EULAR point to consider, we can think about vaccinating the BCG vaccine according to the schedule. However, if the mother was using the non-TNF biological dimers, the infant should delay the BCG vaccination for 6 months. Please go to the next slide. So this is a summary of the EULAR recommendations. Please go to the next slide and move on to the long-term postpartum challenges. Please go to the next slide. I will talk about the long-term maternal CVD risk and long-term follow-up of offsprings. Please go to the next slide. And yeah, I start up from the maternal CVD risk. The cardiovascular disease is the leading cause of the maternal death. Please go to the next slide. And the hypertensive disorders of pregnancy increase the left ventricle mass, and this results in the cardiac remodeling and diastolic dysfunction. Please go to the next slide. So, hypertensive disorders during pregnancy and preeclampsia are the risk factors for the cardiovascular disease and heart failure and diabetes. Please go to the next slide. So we need to keep an eye on the possible development of the cardiovascular disease after the delivery in patients with the preeclampsia during pregnancy. And so close monitoring of these mothers is important. Please go to the next slide. And there's one way to prevent the cardiovascular disease in mothers with the preterm preeclampsia, that is enalapril. If we prescribe the enalapril after delivery, diastolic function improve and every remodeling will improve. So postpartum enalapril can be an option for those mothers with preeclampsia after delivery. Please go to the next slide. And yeah, I will talk about long-term follow-up of children and start up from the risk factors, risk for the autoimmune disease. Please go to the next slide. And if the baby is born to a father or mother with the autoimmune disease, the risk for the development of autoimmune disease will be increased. So please go to the next slide. And the next, I will talk about the neurodevelopmental disorders. Please go to the next slide. If the mother has an autoimmune condition, the risk for the ADHD will increase. And in addition, please go to the next slide. If the mother has an rheumatoid arthritis, the risk for the autism will also increase. So we need to keep an eye on these conditions. And in addition, please go to the next slide. S3 and APS are related to the infants from the S3 or APS has a higher risk to suffer from learning disturbances. So yeah, we need to keep an eye on the neurodevelopmental disorders in infants from mother with autoimmune diseases. So please go to the next slide. So this is a summary slide. Thank you for listening.
Thank you so much, Takahiro. This was really great. It was really an amazing job you did. I know how many of those nice looking slides you had, and you managed to really run through them, but still give every important information. Since we are already a little bit behind time, and at least as far as I know, we do not have any questions in the chat by now, we decided to move on to the last final part in our webinar, so that every one of you can maybe stay 5 to 10 minutes more to hear that. And of course, as this is being recorded, you might also watch it again and again and again, as I have to do since I wasn't able to seize everything that we have heard until now. But if there are some important questions, I think we can get that in the very end. So now for the last part, it's my pleasure to take over. And I would like to give you a brief impulse from what was also discussed at the conference, namely ethical issue and how can we include pregnant patients in clinical trials. Since that has already been taken up before, that we all know we have the problem of a really big data gap and we want to close that. So this is a brief overview of the talks, of the presentations from the conference that I took in my highlight presentation. And first, I would like to start to give you a brief introduction to the principles of bioethics, which are 4 important values which have been brought up historically after, of course, during World War II, some medical experiments have been done to humans who didn't have autonomy, non-maleficence, justice, and so on, to decide if they want to join these experiments or not. And these have been brought up afterwards to be a groundwork for our clinical trials, but at some point, they have also led to an automatic exclusion of pregnant people, this so-called vulnerable population, from research. And that is a problem that we are nowadays dealing with, and of course that our patients are dealing with. Because this exclusion puts the pregnant people and their offspring at risk. Just a brief look at the numbers. We have 200 million pregnant women each year on the whole world. The numbers on how many of those enter their pregnancy with a chronic medical condition differ a bit, but somewhat between 1 of 5 and 1 of 10, I guess, might be the truth. And only 5%, in contrast, of the medications that are on the market are properly tested and labeled for their use in pregnancy. Though there is really a big contrast, a big evidence gap, or I like that phrase from Kathy Nelson-Pirri, very much information vacuum in which we need to deal every day. And this information vacuum, causes several risks. On the one hand, since pregnant women have a lot of changes to their physiology going on, it might even be that with the normal dosage that we use, we have an ineffective treatment. We have a potential undertreatment, or we might have overdosing sometimes, toxicity, etc. But we also, since we don't have any actual data on the safety of this medication for the mother and especially for the fetus, we have to decide to use them or not without adequate safety data. And we usually get some data 10 to 15 years after approval of the medication. So instead of really avoiding a risk, we are just shifting the risk from the time the medication gets on the market until those 10 to 15 years later. Furthermore, if we are reluctant to prescribe to use the medication, then we might also be falsely avoiding a beneficial drug, which would be really important. And overall, all of this is the exclusion from the trials is, somehow the idea of protecting the pregnant women, but it might really be to protect them to death if we take together all the potential risks that I've mentioned. So COVID-19 might have been really a time point to change some things also in the heads, in our minds regarding this. And I would just like to briefly mention this recovery study, a study carried out in the UK, which tried different medications in the treatment of COVID-19. And while pregnant women were excluded from the vaccine trials to COVID-19 before with deleterious outcomes, that was a point where really the women were included in this recovery trial or could be included while pregnant. And that led to a really fast application to a benefit for those pregnant women, and also led to later initiatives where, as you can see here in this publication, we learned a lot from those trials. On the one hand, that clinicians are willing to randomize pregnant women into trials, and on the other hand, that also those women are willing to take part in the trials, and that a lot of barriers that we might think of on those two sides are not even there, but it is rather regarding sponsors, regulators, insurers who might fear some liability issues or so. And that is something that has also been mentioned in one of many initiatives we nowadays have, which are targeting this topic, this issue, and to say, okay, we need to have a change on the a paradigm shift on the mindset, on this culture of exclusion, but also we need to change a lot regarding the regulatory level and so on to really have the sponsors being interested in including those women, to have a financial incentive maybe to reduce cost and complexity as far as possible, and so on. So there is a lot going on this regulatory level that we need to change. Just to briefly mention, just to have the trials on the truck might not be enough. Another problem that we face, and this has been brought up nicely in this poster presentation, which also got a poster award by Nana Solomon-Schmidt, is the labeling of the trucks. So very shortly said, they took out the information that you can find on the regulator sites regarding the different trucks that we use. They blinded them so that you don't know which truck you actually are reading about. And then they asked the people, okay, is this information enough for you to decide if you would use it during pregnancy? And if yes, how would you decide? And just to give you a brief idea, you can see that even for like hydroxychloroquine, where we would all be sure to use it, you have 22% who said, no, the information is not enough to even decide what to do. And if the information was enough, only 11 people here said that they would use it based on this information. And the others would have been something like, yeah, only if it's really necessary, or the red one said like, no, I wouldn't use it based on this information. So that really shows how different the labels are and how, yeah, bad the information really is. And they concluded that altogether, regarding every information, every medication that was taken in 36%, the healthcare professionals would not be able to make a decision upon this information offered. So we really also need to change the labels. But after all those bad news, there is a silver lining. We have a change in the landscape. It has been, changing over the last years, and it now is really, I think, moving forward and bringing some important changes. And I just picked out some initiatives and some statements that might guide the way for the next years. So one thing is this PRGLAC task force, which has formed and has here presented one important message to help shift researcher mindsets away from an assumed exclusion of all pregnant women. The FDA, on the other hand, also, and this was stated a lot throughout the conference, one representative said that we need to protect our pregnant patients through research, not from research, because we really need the data that we now don't have to decide based on that data with our women how to deal with the drugs. The SciAMS, which is a group based in the WHO, especially said we need research which is designed to obtain this knowledge. So we really also need to think about how to design our clinical trials. And that is also something that this UK initiative that you can see here promoted. And they also said that we need to gather the data in explicitly designed studies, not later than the end of phase 3. So not to wait those 10, 15 years to gather some data. And last of all, the EMA also has put up a strategy where they said, okay, beginning from the preclinical data up to post-authorization, we want to use what we have even better, but we also need new methodologies, we need a conceptual shift, and they also have seen that we need improved product communication. So a lot to do, but I think what has been achieved is really that over the whole world, there is an increased awareness now for this topic at various important committees. There are a lot of calls to action, but of course, this now has to get into action. We need specific guidelines on how we should include the pregnant people in our clinical trials. We need regulatory changes. The medical staff who's doing the trials needs to be trained for that and to, in the end, reach the true paradigm shift. So with that, I would like to thank you for your attention for this last, like a bit out of the box part of the RumoPreg 2025. And before we have our maybe questions, if there are any, before we come to the goodbyes, I would really like to thank all of my co-rapporteurs. They went through all their notes. They ran through every information they could get from the conference during the last 1.5 or 2 weeks. They put up all these nice presentations that you have seen, and they managed to deal with me as their slide mover today quite spontaneously. So I want to give, I want you to give them all their like applause that you can give. And with that, I would hand over to Laura Andreoli and Karen Schreiber for some last remarks with upcoming news.
Thank you so much, Isabel. I think you you did a fantastic job in getting this all together, and of course, together with the rapporteur group. This is just really wonderful. I think Clara and Tony, I think you were going to say something about the special issue, and I might just be handing over the word to you for a moment. Thank you.
Thank you very much for everybody. Everybody who made this possible. Am I echoing? Thank you very much for everybody who made this meeting possible and everybody who came and sacrificed more than 1 hour of their life to recap the Roma Prague. It was done really wonderfully. I would love to invite everybody for the special issue of the Frontiers, which deals with the topic of the Roma Prague, to submit their work in this reproductive issue of lupus, antiphospholipid syndrome, or other autoimmune rheumatic diseases, because this is another additional forum to improve our knowledge in this topic. Yeah, thank you very much for coming, and
Thank
please,
you very
Karen.
much.
Thank you. Yes, wonderful. And then I've got the honor to remind everyone that the next Roma Prague conference will be held in Rotterdam in the Netherlands in 2027. And that will be the next time we're going to be seeing the whole world of the Roma Prague family there. So I'm looking forward to that.
And before we say goodbye, we remind you all that there's going to be our annual meeting face-to-face in Barcelona during the EULAR Congress. And for those who are not coming to the Congress, you can connect with this link. And we will circulate it again in the next few weeks. And please, if you are not part of the mailing list yet, reach out to either me or Karen, and we will gladly add you to the list. So congratulations to everyone, and thanks everyone for joining. See you soon.
See you soon.
Bye.
Bye.
Bye. Thank you.
Thank you.